Assalamu alaikum. This presentation is on salivary ranula. Salivary ranulas are mucoceles that originate exclusively from the sublingual gland. They form a pseudocyst. It's not lined by any true epithelium. It's lined by connective tissue and is full of extravasated saliva. It typically presents in the floor of the mouth. The name ranula comes from the Latin word for a small frog. The resemblance is clear, and it can be classified into simple ranula above the floor of the mouth, above the mylohyoid muscle, or a deep or a plunging or a cervical ranula when it penetrates the floor of the mouth deeper to the mylohyoid muscle and present in the neck, the submental, submandibular, or parapharyngeal spaces. Ranulas are most prevalent in the second decade of life. It is slightly more common in females, but plunging ranulas are more common in males. Interestingly, ranulas involve more the left side, but again, a plunging ranula involves much more the right side than the left. There is a certain connection between developing a ranula and being an HIV positive. This was discovered in Zimbabwe in patients group age below 10 years. Ranulas originate from the sublingual gland through rupture of one of the very tiny ducts that comes from the lesser part of the sublingual gland, the ducts of Ravini, and drain directly into the oral cavity. Trauma or rupture or blockage of one of these ducts could lead to the formation of the ranula. This may need just a minor amount of trauma during mastication, for example. There may be also a congenital predisposition for plunging ranulas because the incidence of plunging ranulas in some ethnic groups and tribes in some Pacific islands is much higher than the other parts of the world. There is also this association between being HIV positive and having ranulas in children in Zimbabwe, possibly due to blockage of the salivary glands by inflammation and periductal fibrosis. The sublingual salivary gland, much like the minor salivary glands of the oral cavity mucosa, is a constant producer of saliva. The resting saliva continues to be produced by the gland, unlike the submandibular or the parotid gland, which tends to produce much more saliva if stimulated neurogenically. The saliva from the lesser part of the sublingual gland drains directly into the oral cavity through this tiny ducts of Ravines. There may be up to 20 of them, and a torn or an obstructed duct of them would lead to accumulation, extravasation of the saliva that is constantly produced by the sublingual gland under the surface of the floor of the mouth, the mucous membrane, and this would lead to the formation of the ranula. The mylohyoid muscle is the diaphragm that forms the floor of the mouth. If the ranula extends beyond this floor of the mouth diaphragm, beyond the mylohyoid muscle, it would present into the neck, either in the submental or the submandibular or even the parapharyngeal space. How a ranula could present in the neck, either through the posterior free edge of the mylohyoid muscle or through one or more dehiscences or clefts in the mylohyoid muscle. The mylohyoid muscle is the diaphragm of the floor of the mouth. It separates the sublingual compartment containing the sublingual salivary gland from the submandibular compartment. The sublingual compartment would be superficial and medial, while the submandibular compartment will be posterior and deep. But there is a connection between these two spaces at the posterior edge of the mylohyoid muscle. This is the mylohyoid muscle, posterior edge here. You could see there is nothing that prevents communication between the uncinate process of the deep part of the submandibular gland and the rest of the sublingual gland. Through this communication, infections like pus or discharge or ranulas can communicate easily. To add to this, there is always, or about up to 77% of cadavers, you could see some clefts, some openings or hiatuses in the mylohyoid muscle. This allows the sublingual gland to herniate through the floor of the mouth to lie outside the sublingual space. You could see such a hiatus in here. This is filled with the sublingual herniation, but sometimes it can be filled with fat. This is the submandibular gland, this is the mylohyoid gland, and this is the sublingual salivary gland. So there is a free communication between the two spaces posteriorly at the posterior edge of the mylohyoid, and there may be also communication through the clefts into the mylohyoid muscle, which is present in up to 3/4 of the individuals, and it can be filled with fat or a herniated gland, or it can be unilateral or it can be bilateral. A ranula is diagnosed clinically from its shape and appearance and from its location in the floor of the mouth. It is soft, compressible, has a blue tinge or a hue, and it's painless. And it may follow things like previous oral surgery or intraoral injury or trauma. It's rare for ranulas to present with respiratory or feeding difficulties except in children. And if a patient with a ranula presents with neurological changes such as numbness or weakness of the tongue or numbness of the lip or the hard palate or any induration in the floor of the mouth or loosening of the teeth, then a suspicion of an underlying malignancy, this possibility should be investigated. A plunging ranula would present as a mass in the neck. This would be a soft and a compressible, painless mass that may be persistent or recurrent. It's usually unilateral, rarely bilateral, like in this case. And it affects usually either the submental space or the submandibular space, but if large enough, it can extend to the parapharyngeal space and even can reach the lower part of the neck, and in very few cases it reached the anterior chest wall. The ranulas in the neck, plunging ranulas, are almost always associated with an intraoral component in the mouth. It's very rare for plunging ranulas in the neck to present as an isolated pseudocyst. The bilateral ranulas can be synchronous, like in this case, or they can be metachronous. They can develop after excision of one side ranula. By few years, the contralateral side may develop another ranula. The clinical presentation of ranulas in children is different. Children under the age of 5 years either present with airway compromise or feeding compromise. A feeding compromise would lead to failure to thrive. A compromised airway would present as noisy breathing, snoring, obstructive sleep apnea, and impending upper airway obstruction. The duration should be less than few months, less than 6 months or so. The ranulas itself enlarge slowly and may be palpable if it is plunging into the neck on bimanual palpation. There are rare reports of ranulas in neonates that have required ex utero intrapartum treatment. Exit. Ranulas are mucoceles of the sublingual gland. Their histological appearance resembles those of mucoceles elsewhere in the oral cavity or the pharynx. There will be accumulation of fluid, of saliva, containing high levels of mucin and amylase. surrounded by granulation tissue around. This granulation tissue contains macrophages. Fine needle aspiration will show the mucin and the macrophages, and biochemical analysis of the aspirated fluid would show high levels of amylase and protein, confirming that the origin of the pseudocyst is of salivary origin. The wall of the pseudocyst is made up of the granulation tissue, fibroconnective vascularized tissue, and it lacks an epithelial lining. That's why it's a pseudocyst, not a true cyst. The diagnosis of a ranula is often reached on clinical basis. Imaging is required, however, to assess the extent of the spread of the ranula, whether it's plunging into the neck, and which neck spaces has been invaded. The tail sign of a ranula, this is the ranula here in this CT scan. You could see this tail of the ranula would indicate that there is a plunging ranula component. This is how the ranula extend beyond the posterior edge of the mylohyoid muscle to present into the neck. It's not a constant feature, however, and some plunging ranulas don't show this tail sign. Ultrasound scans are a convenient way of investigating ranulas. They are almost always available in most hospitals, not expensive, and requires a short examination and gives good visualization of the sublingual gland, the sublingual space, the ranula from the sublingual gland, the defect in the mylohyoid muscle in the floor of the mouth, and the plunging ranula in subcutaneous in a part of the neck. MRI scans can also be very valuable in assessing the extent of the ranulas, particularly plunging ranulas. A T1 weighted images would give a low enhancement, but it is the T2 weighted images like in here that will give this bright signal. Of course, if the ranula is infected, and this is not very common, then the signal may vary. Now, a Valsalva maneuver during the MRI scan would increase the intraoral pressure and helps in pushing the ranula fluid in a sublingual ranula. If there is any defect, it would show more prominent plunging ranulas in the neck by the use of this simple maneuver. It would be shown better on coronal cuts of the MRI scan. Also, if the gadolinium was used for the enhancement of the scan, it would show the sublingual glands clearly as well and its relation to the intraoral part of the ranula. And you can also trace the mylohyoid muscle and see any defects in it or extension of the intraoral ranula behind it through the tail sign through the posterior edge of the mylohyoid into the neck. CT scans of plunging ranulas will show a unilocular cyst. This is characteristic of ranulas. Branchial cysts, the differential diagnosis of ranulas, include things like branchial cyst, which would have a much thicker wall and may also have several partitions inside the big cyst. A thyroglossal cyst, the other differential diagnosis, is usually strictly midline or paramedian. A lymph node that has a necrotic center would usually show in the parapharyngeal space with several lymph nodes around as well. The other differential diagnosis would be a salivary gland cystic tumor. And again, coronal cuts with the CT scan can help to detect a plunging component of the ranula in the neck. Some patients may experience spontaneous resolution or rupture of their ranulas. But the vast majority of the patients would require some form of management for their condition. Few of them would have medical treatment. Some would try sclerotherapy, needle aspiration or incision and drainage, or even marsupialization, but most commonly surgery would be indicated in the form of ranula excision or what is more important, the sublingual gland excision with or without the ranula excision. We'll go through all these now. Is there a medical treatment for ranulas? Oral administration of nickel gluconate has been described and tested. At low doses, nickel promotes enzymatic functions and tissue repair process in the salivary glands, and it has been shown that this could help in resolving or controlling the progress of ranula. There are some reported promising results about the use of oral nickel gluconate in the treatment of ranulas. The treatment for oral and plunging ranulas would depend on two main approaches. The number one approach is the control of the saliva leak from the sublingual gland. Sublingual gland will continue to produce saliva, and if there is a leak through a ruptured duct of Revini, then the pseudocyst will continue to accumulate saliva inside. The number two approach after the control of the leak is to evacuate the pseudocyst itself by different methods. For the number one approach, the control of the extravasation of saliva, it's either a resection of the whole or sometimes the part of the sublingual gland. It's usually the whole of the sublingual gland would be removed for definitive control of salivary leak. Or induction of fibrosis to seal the leak. If you work through the ranula itself, sometimes induction of fibrosis around a specific source of a leak could seal that point of leaking and control the condition. The number two issue is to evacuate the cyst itself, knowing that if the leak is controlled, the cyst would involute within a few weeks or so on its own by absorption of the saliva, and the granulation tissue would mature in the pseudocyst, and the pseudocyst itself would involute spontaneously. But other methods had been described for decompression, including evacuation by needle aspiration, or incision of the cyst wall, or marsupialization by removing the roof of the cyst, or even complete surgical resection. Sclerotherapy was tried in the management of ranulas, much like it was tried in the management of mucoceles in the lower lip or in the oral cavity. It was the OK432 agent, sclerosing agent, which is more widely used. It's an anti-neoplastic antibiotic of streptomycin origin, and it was used as a lyophilized mixture of low virulence, and they mix the low virulence streptopyogenes with benzyl penicillin, and then it's injected into the ranula itself. It would induce an inflammatory process and consequently a fibrosis. The injection of OK432, it can be as successful as 3 out of every 4 ranulas in the oral cavity, and about 1 in 2 of plunging ranulas, lower success rates for plunging ranulas. It would work by inducing fibrosis around the area of the salivary leak from the sublingual torn duct of Revini, one of the ducts of Revini, and this would stop the leak, and the induced fibrosis would also help in the involution of the pseudocyst. It would cause pain, however, and fever in at least half of the patients. But it is those patients who have a very brisk inflammatory response in the form of pain and fever that would benefit most. Those are the patients who would actually have a successful outcome. Silver nitrate was also used much in the same way after diluting it and injecting it in the lumen of ranulas. In one series, it was successful in about half of the cases, again by inducing an inflammatory process and fibrosis. Perhaps the oldest way of managing the ranulas was a simple incision on the roof of the ranula, followed by decompressing of its content, aspiration of all the accumulated saliva. This will give an immediate effect, but the recurrence rate was very close to 100%, except for those perinatal oral ranulas, in which a simple incision may be an ultimate way of managing it. It's because the mucosal epithelium of the neonates will proliferate very rapidly and leave around a fistula in what was before the ranula cavity, and this would drain continuously into the oral cavity, preventing any further accumulation of the saliva in a closed space. But simple incision and drainage is no longer done as a curative way in the management of ranulas, except for those tiny group of patients. Marsupialization of the ranula by excising the whole of its roof was an improvement to simple incision on the roof. This has led to some improvement in success rates, but still the recurrence were in the area of 60%, because the soft tissue in the floor of the mouth would soon fall together, and healing of the roof would be so rapid and the ranula would recur. A simple modification to the marsupialization was introduced by Burmage, in which the cavity after marsupialization was packed. And the packing of the cavity led to recurrences in the area of only 10% compared to the usual recurrence of 60% after simple marsupialization. Packing of the cavity prevented the recurrences, the healing of the roof again, and recurrences of the ranula. Another simple modification was to put on a silk suture in the roof of the ranula or a seton. This is called micro-marsupialization. Just putting on a simple silk suture is sufficient to drain the fluid in the cavity, and epithelium would grow around the track of the suture, and this is going to form an exit to any accumulated saliva afterwards. So recurrences has also been reduced. The other modification was to use laser after deroofing the cavity. Laser, which is defocused, was used to coagulate the floor of the deroofed cavity, and this coagulation would induce enough fibrosis to stop any further leakage from one of the tone ducts of the sublingual gland. The next modification came as a suggestion of removing the whole of the ranula by transoral excision. This is well suited for localized ranulas of small size, less than 2 centimeters. They may respond well to this form of treatment, much like any other mucoceles in the lower lip or the palate would respond to transoral excision. They are particularly helpful if the ranula is associated with the orifice of the Wharton's duct, because removing the ranula and marsupializing the Wharton's duct or reimplanting it by ductoplasty could be a definite treatment. But in practice, the majority of ranulas are relatively large at the time of presentation, and the source of salivary secretion from the tone ducts of the sublingual glands are very difficult to pinpoint. So this way of treatment is only tried on those cysts very close to Wharton's duct and very small cysts. Transoral excision of the ranulas can be helped very much by hydrodissection, by injection of saline with lidocaine and 100,000 epinephrine around the pseudocyst. This will not only decrease any bleeding, also make it possible to identify all the important structures in the floor of the mouth, like the lingual nerve and the submandibular duct and the hypoglossal nerve, to lessen the complications and also decrease the chances of recurrence. So that's something that may be tried with transoral excision of the ranulas. The success rate for transoral excision of the ranulas are in the area of 2 in every 3 cases for oral ranula, and maybe 38% or so for plunging ranula. How would it actually work if the ranula is very close to the tone duct of Revini, that is the source of the constant flow of saliva, and the postoperative fibrosis has managed to heal down this area and sealed the flow of saliva from the sublingual gland, then this operation would be successful. Again, it's very difficult to pinpoint which duct is actually the source of the salivary leak, so the success rate remains in the area of 2 in every 3 cases. And then came a decisive suggestion about excising of the whole of the ipsilateral sublingual gland. This is the most predictable method of eradicating ranulas, and the results conclusively show a very low recurrence rate in the area of about 1%. So this is the method of choice basically for the ultimate treatment of ranulas, but it may be associated with several complications because this would entail working very close to the lingual nerve or the Wharton's duct, and this can cause possible stenosis of the duct with obstructive salidinitis in the submandibular gland or duct laceration. There may also be bleeding and hematoma in the floor of the mouth, and occasionally hypoglossal nerve can be also injured. But removing the sublingual gland is the ultimate treatment for preventing any recurrences of the ranulas. And once the sublingual gland itself is removed, it's no longer important to remove the ranula cavity itself, because once the sublingual gland is removed with the constant flow of saliva that feeds into the ranula, the cavity itself would involute spontaneously and eventually disappear. And this notion was confirmed by several authors that excision of the pseudocyst forming the ranula is probably unnecessary once the ipsilateral sublingual gland is excised. It is the excision of the sublingual gland that actually makes the difference. The recurrence rates would drop in the cases of sublingual gland excision to around 1%. The ranula itself can be left to involute, and this would save any extra risks to surrounding structures, particularly if it is a plunging ranula into the neck. Here is the imaging anatomy of the sublingual gland on this MRI scan. You could see the almond-shaped flat structure of the sublingual gland. It measures about 3 centimeters in a sagittal plane, and its weight is again about 3 grams. This is just about 20% of the weight of the much larger submandibular gland. Again, starting from posterior to anterior, you could see the intrinsic muscles of the tongue first, followed anteriorly by the genioglossus in here. In between the genioglossus and the mandible, you could see the sublingual gland proper. The posterior part of the sublingual gland would take you to the furthest anterior point of the deep part of the submandibular gland. On this cross-section, it would be a U-shaped structure because it straddles the mylohyoid posterior edge. And in between the gland and the tongue, you could see the lingual artery, and you could see also the submandibular duct in there, and this would be the mandible. And further laterally, you could see for the gland itself, like a bit laterally and inferiorly, there would be parts of the mylohyoid muscle. The posterior part of it would dent in this section, the submandibular salivary gland. For surgical exposure of the sublingual gland, the floor of the mouth may be pushed manually upwards in order to flatten the structures in the floor of the mouth to aid in the dissection. The mucosa of the floor of the mouth, rather than being just incised, would be, you'd have an elliptical excision of the mucosa overlying the sublingual gland. Why? Because it's very difficult to detach this oral mucosa from the sublingual gland. It's firmly attached to it, and it is perforated like 15 to 20 times with these minor salivary glands ducts. So it's better just to excise this part of the mucosa in order to gain exposure to the floor of the mouth structures. You could see here the submandibular duct, and you could see here the lingual nerve. These should be identified very early in the exposure and isolated and protected. The drainage of the sublingual gland into the Wharton's duct is also of surgical importance. If the gland is to be excised, this drainage has to be sealed, otherwise there will be a hole in the salivary gland duct, the Wharton's duct, or else the Wharton's duct would have to be marsupialized and through a separate incision in the floor of the mouth mucosa and brought about from there. The intraoral surgery to remove the ranula and the sublingual gland would start with the identification and stenting of the Wharton's duct to prevent its injury. Then the mucosa overlying the sublingual gland, an elliptical excision of the whole mucosa over the gland would be undertaken rather than just an incision, because it's very difficult to dissect this mucosa from the gland due to the exit of about 20 different short valves of Ravini. This is followed by a lateral dissection to the gland itself, and then the medial dissection between the gland and the ranula to dissect it from the Wharton's duct. The posterior dissection will then be carried out, preserving the lingual nerve and the hypoglossal nerve. And once the gland and the ranula are removed, the Wharton's duct would be checked. If there is any injury or any tear, it can be marsupialized to the mucous membrane of the oral cavity to allow better drainage rather than trying to repair this. And the wound would be closed with absorbable suture in a single layer. Occasionally, if there is a small plunging ranula, it can be removed intraorally as well as the sublingual and the intraoral ranula. But in most cases, if the plunging ranula is big enough, it would need to be excised through a neck incision, placed 3 finger breadths below the inferior margin of the mandible in a skin crease. The next step would be to mobilize the submandibular gland away from the ranula, preserving the duct of the gland throughout the steps of the operation. And then the ranula, the plunging ranula posterior and inferior extents would be dissected, and the ranula would be delivered through the oral cavity or through the open wound in the neck. The facial artery, vein, and mandibular branch of the facial nerve would have to be identified and preserved as well. A review of over 500 cases analyzing surgical complications shows that the most reported complications were recurrence of the ranula in about 6% of the cases, and injury to the lingual nerve in about 5% of the cases, injury to Wharton's duct in just less than 2% of the cases, and injury to the hypoglossal nerve in lesser percentages. These complications usually present immediately, but commonly resolve within a time span of 2 to 7 months. The weakness of the tongue that can occur from injury to the hypoglossal nerve is also usually transient and would resolve with time. The recurrence rate of the ranula are not related to the size of the ranula, the swelling pattern, or the approach through the oral cavity or through the neck. It's not also related to whether the ranula has ruptured during the dissection or not, but it is related to the choice of the surgical procedure. In one big series, if the choice was aspiration only, the recurrence rate was 100%. If it was marsupialization only, the recurrence rate was almost 2 in every 3 cases. If excision of the ranula without removing of the sublingual gland was the choice, the recurrence rate was about 57%. But excision of the sublingual gland and the gland combined with the lesion had the lowest recurrence rate at about 1.2%. The other complications to try to avoid is injury to the Wharton's duct. The Wharton's duct, the yellow part here, is intimately related to the sublingual gland and a part of the gland that drains into the Wharton's duct. The lesser sublingual gland, the lesser part of the sublingual gland, drains directly into the oral cavity through the ducts of Ravini, while the greater part of the sublingual gland, the part that is runs below the submandibular duct, drains through a single duct close to the ampulla of the Wharton's duct. So stenting the duct early during the surgical procedure would help, but it can nevertheless be injured during the dissection or even during the repairing of the tissues in the floor of the mouth. If the duct is injured, attempts at repair can sometimes be useful, or attempt at marsupialization of the injured part into the oral cavity. But if repairing or marsupialization would not be sufficient to drain the submandibular gland, then excision of the whole gland during the surgical session would be advised to avoid obstructive complications of the submandibular gland. And finally, to sum up, ranulas are extravasation salivary cysts, the vast majority of which arise from the ipsilateral sublingual gland. The condition is uncommon and few surgeons will encounter more than one ranula per year. The reliable method of management would be the excision of the ipsilateral sublingual gland, but this surgery is demanding and there is certain definite complications and morbidities with this operation. A simpler approach may be suggested that is open to all skill levels, which is marsupialization of the ranula with additional packing of the pseudocyst. This will reduce the recurrence rate to around 10% only. Persistent or recurrent ranulas can only be dealt with through sublingual gland excision. By this, we come to the end of this presentation on salivary ranula. Assalamu alaikum.